Alright, now we're going to read about oxygen therapy. This is continuing on our Module 3 gas exchange. We read this, reviewed that. Now we're going to read these bad boys. Here we freaking go. I'll start here. Read loud.
Oxygen therapy is the administration of supplemental oxygen, O2, to a patient to prevent or treat hypoxemia. Hypoxemia. Routes of administration include, but are not limited to, nasal cannula, face masks, non-invasive ventilation, and positive pressure ventilators. Special care is required for each of the separate delivery devices. Standards of care. AARC Clinical Practice Guideline, 2012 Humidification. Principles for practice. Oxygen therapy is used in a variety of conditions to treat hypoxia, which is a condition in which there is insufficient oxygen to meet the metabolic demands of the tissues and cells. Box 23.1. Box 23.1. Signs and symptoms associated with acute hypoxia. Apprehension, anxiety, behavioral changes. Decreased level of consciousness, confusion, drowsiness, altered concentration. Increased pulse rate. Increased rate and depth of respiration or irregular respiratory patterns. Decreased lung sounds, adventitious lung sounds, example crackles, wheezes. Elevated blood pressure evolving to decreased blood pressure. Pulse oximetry, SpO2, less than 90%. Dyspnea. Use of accessory muscles of respiration, rib retractions. Cardiac dysrhythmias. Pallor, cyanosis. Increased fatigue. Dizziness. Hemoglobin is the carrier of respiratory gases, oxygen, and carbon dioxide, CO2. It combines with the gas to carry it to and from the cells. Decreased hemoglobin levels reduce the amount of oxygen transported to the cells and carbon dioxide transported away from the cells. Hemoglobin levels and acid-base status directly affect oxygenation. Acidemia increases the ability of hemoglobin to release oxygen to the tissues. Alkalemia decreases the ability of hemoglobin to release oxygen to the tissues. Pain and anxiety affect patient oxygenation. Therefore assess patient's pain, pulse oximetry. Oximetry, SpO2, values, level of consciousness, developmental level, and observed behaviors, Hockenberry and Wilson, 2015, Lewis et al., 2017. Treat oxygen therapy as a medication. As with any drug, continuously monitor the dosage or concentration of oxygen and routinely check the healthcare provider's orders to verify that the patient is receiving the prescribed oxygen concentration. Follow the 6 rights of medication administration when administering oxygen, see Chapter 20. Contraindications to oxygen therapies include those that increase the patient's risk for respiratory failure. For example, patients with certain types of congenital heart defects and chronic pulmonary diseases should receive oxygen sparingly. In patients with congenital heart defects, oxygen affects blood flow through the heart and lungs. In patients with chronic pulmonary diseases, oxygen therapy increases the patient's risk for elevated carbon dioxide in the blood, hypercapnia. Patient-centered care. Take time to explain to the patient and family caregiver the oxygen setup and necessary safety precautions needed when oxygen is in use. Patients and visitors with limited English proficiency may not be able to understand signs posted in the room and need help. Safely accommodate valued practices of cultural groups when using oxygen. For example, some cultures burn incense, which does not have a flame, to promote healing of ill members. When oxygen is used in the home, designate areas where patients can safely burn incense and encourage family members to bring the ashes to the bedside. Some cultures light candles to celebrate or honor holidays and may accept the use of battery-operated candles while in the hospital. Spector, 2013. Collaborate with family members and religious leaders about how to accommodate these practices during illness and recovery. Evidence-based practice. Recent research suggests that high-flow nasal cannula, HFNC, may be used in place of non-invasive positive pressure ventilation, NPPV, in certain patients with acute respiratory failure, Gaunt et al., 2015. It may also be used instead of bag valve mask ventilation when pre-oxygenating patients immediately before intubation, Messica et al., 2015. Early studies indicate that the use of ventilator-associated pneumonia, VAP, prevention bundles have decreased the rates of VAP, Ch23 et al., 2015. The Institute for Healthcare Improvement, IHI, 2012, created the 5-step ventilator bundle, Box 23.2. Box 23.2. Care bundle for ventilator-associated pneumonia. Good hand hygiene. Internal endotracheal cuff pressure at 25 to 30 centimeters H2O every 2 hours. Head of bed at 30 to 45 degrees. Prophylaxis for deep vein thrombosis and peptic ulcer disease. Daily interruptions of sedation to assess accurately for readiness to extubate. Oral care with chlorhexidine 0.12% every 12 hours and general oral care every 2 hours secondary to microbial colonization within the mouth. Complete subglottal suctioning to decrease risk of oral fluid aspiration. Accurate and timely documentation. Timely ventilator circuit changes and removal of condensation. Provide for mobility through turning and repositioning every 2 hours. There are significant issues regarding defining VAP and ventilator-associated events, V's, Munico et al., 2014. The Centers for Disease Control and Prevention, CDC, developed a lengthy algorithm for clinicians to use to accurately diagnose these complications. This algorithm can be viewed at http://www.cdc.gov/nhsn/pdsc/manual/10-v_final.pdf. The key points in the definition of B are the deterioration in respiratory status after a period of stability or improvement on the ventilator, evidence of infection or inflammation, and laboratory evidence of respiratory infection. Patients must be mechanically ventilated for more than 2 calendar days to be eligible for V. CDC, 2016, p. 10-3. Adult patients who have received mechanical ventilation reported several feelings during their experience, including fear caused by dependence on ventilator and loss of control of their life, disconnection from reality, impaired sense of body image, development of adaptation patterns, including maintaining a strong belief and developing communication methods, feeling concern and caring from others, including healthcare professionals, who help patients' sense of security, Ch23, 2013. NPPV does not have a significant effect on gas exchange, exercise tolerance, lung function, respiratory muscle strength, or sleep efficiency in patients with chronic obstructive pulmonary disease, COPD, Ch23, 2013. There is no evidence to support that incentive spirometer, IS, alone prevents pulmonary complications in patients who have undergone upper abdominal surgery, do Nascimento et al., 2014, Tyson et al., 2015. Safety guidelines. Know a patient's normal range of vital signs and pulse oximetry, SpO2, values. Be aware of environmental conditions. Patients with chronic respiratory diseases have difficulty maintaining optimal oxygen levels in polluted environments. If a patient is to receive home oxygen therapy, complete an environmental assessment to determine respiratory hazards in the home such as the use of gas stoves or kerosene space heaters or the presence of smokers in the home, see Chapter 43. Document a patient's smoking history. Smoking damages the mucociliary clearance mechanism of the lungs and paralyzes the ciliary action, resulting in a decreased ability to clear mucus from the airways. Chronic bronchitis is caused primarily by smoking and results in pooling of mucus in the airways, creating an environment for the development of infections. Long-term chronic bronchitis ultimately results in hypoxia. Know a patient's most recent hemoglobin values and past and current arterial blood gas, ABG, values. Oxygen is a medication. Increasing the oxygen liter flow rate for shortness of breath is similar to doubling heart, asthma, or other medications. Provide education to patient and family about home oxygen therapy so they understand proper use of the equipment. Safety measures for oxygen use are very important, see Chapter 43, Box 23.3. Box 23.3. Oxygen Safety Guidelines. Remind patients that oxygen is a medication and is not adjusted without a healthcare provider's order. In the home setting, place an oxygen in use sign on the door of the residence. Keep oxygen delivery systems at least 5 feet from any heat source, American Lung Association, 2016. Oxygen supports combustion, however, it will not explode. No smoking is allowed on the premises. When using oxygen cylinders, secure them so they will not fall over. Store oxygen cylinders upright, chained, or in appropriate holders. Determine that all electrical equipment in the room is functioning correctly and properly grounded, see Chapter 14. An electrical spark in the presence of oxygen will result in a serious fire. Avoid using items that create a spark, example electric razor, with a nasal cannula in use, an electrical or mechanical toy, an oxygen tent, or objects of synthetic fabrics that cause static electricity. Check the oxygen level of portable tanks before transporting a patient to ensure that there is enough oxygen in the tank. Have suction equipment available to help clear airway secretions, particularly in patients with artificial airways such as an endotracheal tube or tracheostomy. Most agencies require that a self-inflating resuscitation bag and appropriate size mask should be available in patient rooms, particularly in patients requiring mechanical ventilation. Skill 23.1 Applying an oxygen delivery device. Video clip. Various diseases, example pneumonia, chronic obstructive pulmonary disease COPD, require the use of oxygen therapy. Pneumonia results in impaired gas exchange because of fluid and secretions in the lung, which decrease the diffusion of oxygen from the lungs to the arterial blood supply. Some patients with COPD require the use of oxygen, particularly at home. These patients may require oxygen 24 hours a day, therefore care is taken to plan administration around patient needs, Grindrod, 2015. Oxygen delivery devices. Oxygen therapy is inexpensive, widely available, and used in a variety of settings. Patients with decreased tissue oxygenation benefit from controlled oxygen administration. Long-term oxygen treatment can improve survival in COPD, Grindrod, 2015. Selection of the type of oxygen delivery system is made on the basis of the level of oxygen support that the patient needs, the severity of the hypoxia, and the disease process. Consider other factors such as the patient's age and developmental level, level of health and orientation, presence of an artificial airway, whether the setting is in the hospital or the home, type of home environment, and type of support and care given after discharge. Oxygen delivery devices fall into one of two categories, high flow or low flow, depending on their ability to provide enough flow to match the patient's spontaneous minute volume. Matching a patient's spontaneous minute volume is imperative for patient comfort and adequate oxygen delivery. High-flow devices discourage in-training room air, which dilutes the inspired oxygen concentration, FiO2. High-flow devices include Venturi mask, Fig 23.1, large volume nebulizer, and blender masks. A newer type of high-flow device is the high-flow nasal cannula, Fig 23.2. Low-flow devices include nasal cannula, Fig 23.3, and simple face mask, Fig 23.4, non-rebreather, and partial rebreather masks, Fig 23.5. These devices deliver set percentages of oxygen, and each one has advantages and disadvantages. You can estimate approximate FiO2 by the flow rate, Table 23.1. Fig 23.1 Venturi mask. Fig 23.2 high-flow nasal cannula. Courtesy Fisher and Paykel Healthcare. Fig 23.3 nasal cannula adjusted for proper fit. Fig 23.4 simple face mask. Fig 23.5 plastic face mask with reservoir bag. Table 23.1. Oxygen delivery systems. Delivery system. FiO2 delivered. Advantages. Disadvantages. Low-flow delivery devices. Nasal cannula. 1 to 6L/min, 24%-44%. Safe and simple. Easily tolerated. Effective for low concentrations. Does not impede eating or talking. Inexpensive, disposable. Unable to use with nasal obstruction. Drying of mucous membranes. Can dislodge easily. May cause skin irritation or breakdown. Patient's breathing pattern affects exact FiO2. Oxygen conserving cannula, Oximetry. 8L/min, up to 30%-60%. Indicated for long-term O2 use in the home. Allows increased O2 concentration and lower flow. Cannula cannot be cleaned. More expensive than standard cannula. Simple face mask. 6 to 12L/min, 35%-50%. Useful for short periods of time such as patient transportation. Normal. Patient's work of breathing decreases. Pulmonary conditions such as pneumonia or asthma cause varying degrees of airway narrowing. With improved oxygenation, patient's airways are open, and work of breathing decreases. Patient experiences increased lung expansion. Improved oxygenation helps to resolve collapsed and constricted airways, improves work of breathing, and thus improves lung expansion. Patient's level of consciousness, LOC, returns to baseline. Improvement in oxygenation relieves hypoxia and improves patient's mental status. Patient verbalizes improved levels of comfort, and subjective sensations of anxiety, fatigue, and breathlessness decrease. Increased oxygen levels in the blood reduce patient's anxiety, fatigue, and breathlessness. Patient's ears, nares, and nasal mucosa remain intact. Intact skin indicates no device-related pressure to underlying skin and mucous membrane, Pittman et al., 2015, Shalom et al., 2015. To explain procedure to patient and family caregiver. Explanation decreases patient's anxiety and reduces oxygen consumption. Increases adherence and cooperation of patient and family caregiver. 3. Gather equipment/supplies and complete necessary charges according to agency policy. Provides organized implementation of the oxygen delivery device. Implementation. 1. Perform hand hygiene. Apply face shield if risk of exposure to splashing mucus exists. Apply gloves if patient has oral or nasal secretions. Reduces transmission of microorganisms. 2. Adjust bed to appropriate height and lower side rail on side nearest you. Check locks on bed wheel. Minimizes caregiver's muscle strain and prevents injury. Prevents bed from moving. 3. Attach oxygen delivery device, example cannula, mask, to oxygen tubing and attach end of tubing to humidified oxygen source adjusted to prescribed flow rate, see Fig 23.6. Humidity prevents drying of nasal and oral mucous membranes and airway secretions. Flow meters with smaller calibrations may be required for patients requiring low-dose oxygen such as pediatric patients or patients with chronic obstructive pulmonary disease, COPD, Hockenberry and Wilson, 2015, Restrepo and Walsh, 2012. 4. Apply oxygen device. 8. Place tips of the cannula into patient's nares. If tips are curved, they should point downward inside nostrils. Then loop cannula tubing up and over patient's ears. Adjust lanyard so cannula fits snugly but not too tight without pressure to patient nares and ears, see Fig 23.3. Tips of cannula direct flow of oxygen into patient's upper respiratory tract. B. Apply a mask by placing it over patient's mouth and nose. Then bring straps over patient's head and adjust to form a comfortable but tight seal, see Fig 23.4. A properly fitting device that does not create pressure on nares or ears is comfortable, and patient is more likely to keep it in place, reduces risk for skin breakdown, Shalom et al., 2015. 5. Maintain sufficient slack on oxygen tubing and secure to patient's clothes. Allows patient to turn head without causing mask to shift position or dislodge nasal cannula. 6. Observe for proper function of oxygen delivery device. Ensures patency of delivery device and accuracy of prescribed oxygen flow rate, see table 23.1. A nasal cannula. Cannula is positioned properly in nares, oxygen flows through tips. Provides prescribed oxygen rate and reduces pressure on tips of nares. B. Partial or non-rebreather mask, see Fig 23.5. Mask seals tightly around mouth. Reservoir fills on exhalation and almost collapses on inspiration. Reservoir should not collapse completely. Easily humidifies oxygen and does not dry mucous membranes, Restrepo and Walsh, 2012. Useful for short-term therapy of 24 hours or less. C. Oxygen conserving cannula, oximizer fit as for nasal cannula. Reservoir is located under patient's nose or worn as a pendant. Delivers higher flow of oxygen with nasal cannula. Delivers to 1 ratio, example 6L/min. Nasal cannula is approximately equivalent to 3.5 L/min with oximizer device. D. Non-rebreather mask, apply as regular mask. Contains one-way valves with reservoir, exhaled air does not enter reservoir bag. Can be combined with nasal cannula to provide higher inspired oxygen concentration, FiO2. Device of choice for short-term high FiO2 delivery. Valves on mask side ports permit exhalation but close during inhalation to prevent inhaling room air. E. Simple face mask, select appropriate flow rate, see Fig 23.4. Used for short-term oxygen therapy. F. Venturi mask, see Fig 23.1. Apply as regular mask. Select appropriate flow rate, see table 23.1. Used when high flow device is desired. G. Face tent, see Fig 23.10. Apply tent under patient's chin and over mouth and nose. It will be loose, and a mist is always present. Excellent source of humidification, however, you cannot control oxygen concentrations, and patient who requires high oxygen cannot use this device. H. High flow nasal cannula, see Fig 23.8. Fit as for nasal cannula. Used when high oxygen delivery is required. 7. Verify setting on flow meter and oxygen source for proper setup and prescribed flow rate. Ensures delivery of prescribed oxygen therapy in conjunction with specific cannula/mask. 8. Check cannula/mask every 8 hours or as agency policy indicates. Keep humidification container filled at all times. Ensures patency of cannula and oxygen flow. Oxygen is a dry gas. When it is administered via nasal cannula of 4 L/min or more, you must add humidification so patient inhales humidified oxygen, ATS, 2015a. 9. Post oxygen in use signs on wall behind bed and at entrance to room. Alerts visitors and care providers that oxygen is in use, ATS, 2015a. 10. Properly dispose of gloves, if used, and perform hand hygiene. Reduces transmission of microorganisms. Evaluation. 1. Monitor patient's response to changes in oxygen flow rate with SpO2. Note, monitor ABGs when ordered, however, obtaining ABG measurement is an invasive procedure, and ABGs are not measured frequently. Continual monitoring with SpO2 is required for patients on oxygen therapy. Base changes in supplemental oxygen on individual patients' oxygen saturation levels. 2. Perform physical assessment, listening to lung sounds, palpating chest excursion, inspecting color and condition of skin, and observing for decreased anxiety, improved LOC and cognitive abilities, decreased fatigue, and absence of dizziness. Measure vital signs. Evaluates patient's response to supplemental oxygen. As patient's oxygen level improves, physical signs and symptoms improve. 3. Assess adequacy of oxygen flow each shift or as agency policy dictates. Ensures patency of oxygen delivery device. 4. Observe patient's external ears, bridge of nose, nares, and nasal mucous membranes for evidence of skin breakdown. Oxygen therapy sometimes causes drying of nasal mucosa. The delivery device can cause skin breakdown where device comes in contact with face, neck, and ears. Shalom et al., 2015. 5. Use teach back. I want to be sure I explained how oxygen will help you. Explain to me why oxygen is beneficial for you to use right now. Revise your instruction now or develop a plan for revised patient or family caregiver teaching if patient or family caregiver is not able to teach back correctly. Determines patient's and family caregiver's level of understanding of instructional topic. Unexpected outcomes. Related interventions. 1. Patient experiences skin irritation or breakdown, example at ears, bridge of nose, nares, other pressure areas, sinus pain, or epistaxis. Increase humidification to oxygen delivery system. Provide appropriate skin care. Do not use petroleum-based gel around oxygen because it is flammable. American Lung Association, 2016. 2. Patient experiences continued hypoxia. Notify healthcare provider. Obtain healthcare provider's orders for follow-up SpO2 monitoring or ABG determinations. Consider measures to improve airway patency, including but not limited to coughing techniques and oropharyngeal or orotracheal suctioning. 3. Patient experiences nasal and upper airway mucosa drying. If oxygen flow rate is greater than 4 L/min, use humidification, Restrepo and Walsh, 2012. At rates greater than 5 L/min, nasal mucous membranes dry, and pain in frontal sinuses may develop. Lewis et al., 2017. Assess patient's fluid status and increase fluids if appropriate. Provide frequent oral care. Recording and reporting. Record the respiratory assessment findings, method of oxygen delivery, oxygen flow rate, patient's response to intervention, any adverse reactions or side effects, or change on flow sheet in nurse's notes in electronic health record, AIR, or chart. Document your evaluation of patient and family caregiver learning. Report any unexpected outcome to healthcare provider or nurse in charge. Special considerations. Teaching. If oxygen therapy continues after discharge, teach patient and family caregiver the importance of and rationale for it, how to use the oxygen delivery device, how to contact the supplier of medical equipment, and when to contact the healthcare provider. See Chapter 44. Discuss safety precautions for oxygen use. See Box 23.3, with patient and family caregiver. Discuss signs of carbon dioxide retention, example confusion, headache, decreased LOC, somnolence, carbon dioxide narcosis, respiratory arrest, that patient or family caregiver needs to report to the healthcare provider. Pediatric. Some infants and small children are able to tolerate a nasal cannula. Secure the prongs of the cannula with transparent tape or strips of transparent dressing over the child's cheek. Sometimes infants receive oxygen therapy via an oxygen hood. Place the hood over the patient's head. See Fig 23.10. Inspect toys placed in the tent for safety and suitability. Any source of sparks, example from mechanical or electrical toys, is a potential fire hazard. Hockenberry and Wilson, 2015. Provide comfort and reassurance to the child. Make sure that he or she is able to see someone nearby. Children may still be held by their parents while receiving oxygen via nasal cannula or face mask. Hockenberry and Wilson, 2015. Gerontological. Because of the fragility of older adult skin and mucous membranes, offer oral hygiene and skincare more frequently. Water-based gels such as Aquagel are useful but also dry quickly and need more frequent application. Home care. Obtain appropriate referrals to determine if patient meets the standards for third-party reimbursement. Example PAO2 55 mm Hg or less or SAO2 less than 88%. Exceptions apply when patients have pulmonary hypertension, cor pulmonale, erythrocytosis, edema, or impaired mental status. They are eligible with a PAO2 of 56 to 59 mm Hg, ATS, 2015b. Oxygen tubing in the home setting is available in lengths of 15 m, 50 feet. Provide information about a reliable oxygen therapy equipment vendor within the community to determine if patient and family are able to use a home fill system with an oxygen concentrator, which provides patient opportunity to fill portable canister as needed. Agui-RETAL, 2015. Consider using oxygen-conserving devices, example oximetry, that administer oxygen in a pulse-dosed flow during inhalation only. These reduce the use and cost of long-term oxygen therapy. Skill 23.2 Administering oxygen therapy to a patient with an artificial airway. Patients with an artificial airway require constant humidification to the airway. See Chapter 25. An artificial airway bypasses the normal filtering and humidification process of the nose and mouth. The two devices that supply humidified gas to an artificial airway are a T-tube and a tracheostomy collar. The T-tube, also called a Briggs adapter, is a T-shaped device with a 15 mm connection that connects an oxygen source to an artificial airway such as an endotracheal, ET, tube or tracheostomy, Fig 23.12. A tracheostomy mask is a curved device with an adjustable strap that fits around the patient's neck, Fig 23.13. Fig 23.12 T-tube. Fig 23.13 tracheostomy mask. Courtesy Mark Pack Company. Delegation and Collaboration. The skill of administering oxygen therapy to a patient with an artificial airway cannot be delegated to nursing assistive personnel, NAP. The nurse collaborates with the respiratory therapist when caring for this patient. The nurse directs the NAP about patient-specific variations for application or adjustment of the T-tube or tracheostomy collar, example methods to avoid device-related pressure areas or pulling on the artificial airway, methods for handling accumulated secretions in devices. Immediately reporting to the nurse increase in anxiety, changes in vital signs, and increase in airway secretions. Steps/rationale. Assessment. 1. Identify patient using at least 2 identifiers, example name and birthday or name and medical record number, according to agency policy. Ensures correct patient. Complies with the Joint Commission standards and improves patient safety, TJC, 2016. 2. Perform hand hygiene. Assess patient's respiratory status, including symmetry of chest wall expansion, respiratory rate and depth, sputum production, and lung sounds. See Chapter 6. Assess for signs and symptoms associated with hypoxia. See Box 23.1. Assess condition of lips around endotracheal tube or of tracheal stoma. Note, apply clean gloves if there is risk of contacting mucus. Apply mask if there is risk of mucus splash. Changes in ventilation and gas exchange resulting in hypoxia require oxygen therapy. Provides baseline for monitoring of tissue breakdown from irritation of medical device. Reduces transmission of microorganisms. 3. Observe for patent airway and remove airway secretions by having patient cough and by suctioning. See Chapter 25. Secretions plug airway, decreasing amount of oxygen available for gas exchange in lung. Secretions also occlude T-tube or tracheostomy collar, impeding oxygen delivery to patient. 4. Observe for behavioral changes, example apprehension, anxiety, confusion, decreased ability to concentrate, decreased LOC, fatigue, and dizziness. Decreased levels of oxygen, hypoxia, or increased levels of carbon dioxide, hypercapnia, affect a person's cognitive abilities, interpersonal interactions, and mood. Lewis et al., 2017. Clinical decision point. Patients with artificial airways who develop sudden changes in their vital signs, level of consciousness, LOC, or behavior may be experiencing hypoxia secondary to airway obstruction. Obstruction. The airway must be determined to be patent before oxygen is administered. If patients continue with signs of hypoxia once obstruction is removed or ruled out, oxygen should be applied. 5. Monitor pulse oximetry, SpO2, and, if available, note patient's most recent arterial blood gas, ABG, results. Remove gloves and other PPE, perform hand hygiene. Objectively documents patient's pH, arterial oxygen, arterial carbon dioxide, or arterial oxygen saturation. 6. Review patient's medical record for medical order for oxygen, noting delivery method, flow rate, and duration of oxygen therapy. Ensure safe and accurate oxygen administration. Safe oxygen delivery includes the 6 rights of medication administration, see Chapter 20. 7. Assess patients' and family caregivers' level of understanding of purpose of oxygen therapy. Determines level of instruction or support needed. Nursing diagnoses. Anxiety. Deficient knowledge regarding purpose of therapy. Fatigue. Impaired gas exchange. Ineffective airway clearance. Ineffective breathing pattern. Risk for impaired tissue integrity. Related factors are individualized based on patient's condition or needs. Planning. 1. Expected outcomes following completion of procedure. Patient signs of hypoxia are reduced or eliminated. Patient demonstrates improved oxygenation. Patient's vital signs remain stable or return to baseline. When there is no underlying cardiovascular disease, patient adapts to decreased oxygen levels by increasing pulse and blood pressure. This is a short-term adaptive response. Once signs of hypoxia are reduced or controlled, patient's vital signs usually return to normal. Patient's work of breathing decreases. With improved oxygenation, tissue oxygen demand is met, and work of breathing decreases. Patient experiences increased lung expansion. Improved oxygenation helps to resolve collapsed and constricted airways, improve work of breathing, and thus improve lung expansion. Patient's LOC returns to baseline. Improvement in oxygenation relieves hypoxia and improves patient's mental status. ABG values or SpO2 saturation returns to normal or baseline. Documents physiological response to oxygen therapy. Tracheal stoma remains intact without irritation or peristomal skin breakdown. Tension on tracheal stoma from oxygen therapy equipment has potential to cause pressure on stoma and surrounding skin. Pittman et al., 2015. To explain purpose of T-tube or tracheostomy collar to patient and family caregiver. Explanation decreases patient's anxiety and reduces oxygen consumption. Education increases adherence to treatment plan and cooperation of patient and family caregiver. Implementation. 1. Gather equipment/supplies and complete necessary charges according to agency policy. Ensure that you have the necessary equipment to apply oxygen delivery device appropriately. 2. Perform hand hygiene, apply clean gloves and goggles, consider use of barrier gown and mask. Reduces transmission of microorganisms by preventing contact with pulmonary secretions. Patients with excessive secretions or forceful productive coughs place caregiver at risk for splash contact. 3. Attach T-tube or tracheostomy mask to large bore oxygen tubing and to humidified room air or oxygen source as indicated. Provide supplemental humidification to avoid drying of airway. This is necessary because of loss of oral and nasal passages that naturally humidify air. 4. If healthcare provider orders oxygen, adjust flow rate to 10 L/min or as ordered. Adjust nebulizer to proper oxygen concentration, FiO2, setting. Attach T-tube to artificial airway. Place tracheostomy collar over tracheostomy tube and adjust strap so it fits snugly. Flow rate ensures humidification, nebulizer regulates FiO2. 5. Observe that T-tube does not pull on artificial airway or cause pressure on adjacent skin and tissue. Observe for secretions within T-tube or tracheostomy collar and suction as necessary, see Chapter 25. Pulling effect on tube increases patient's discomfort and causes pressure to side of patient's mouth or tracheal stoma, which increases risk for device-related pressure injuries. Pittman et al., 2015, Shalom et al., 2015. 6. Observe oxygen tubing frequently for accumulation of fluid caused by condensation. If fluid is present, drain tube away from patient, disconnect from collar or T-tube, and discard fluid in proper receptacle. Excess water is medium for bacterial growth. Draining contaminated water into proper receptacle prevents contamination of entire humidifying unit. 7. Set up suction equipment at patient's bedside. Humidification increases airway secretions. 8. Remove personal protective equipment, gloves, goggles, mask, and / or gown, perform hand hygiene. Reduces transmission of microorganisms. Evaluation. 1. Monitor patient's vital signs and SpO2. Continuous monitoring of vital signs and SpO2 allows for continual non-invasive, cost-effective trending of patient's vital signs and oxygen saturation. 2. Perform respiratory assessment and observe for any behavioral changes indicative of hypoxia. Monitors changes in patient's respiratory assessment and cognitive status in response to supplemental oxygen. 3. Observe position of oxygen delivery device and condition of adjacent tissues to ensure that there is no pulling on artificial airway or pressure areas. Pulling on artificial airway or pressure on adjacent tissues results in damage to oral cavity or stoma. 4. Use teach back. I want to be sure I explained how oxygen will help your mother. Explain to me why oxygen is attached to your mother's tracheostomy tube. Revise your instruction now or develop a plan for revised patient or family caregiver teaching if patient or family caregiver is not able to teach back correctly. Determines patient's and family caregiver's level of understanding of instructional topic. Unexpected outcomes. Related interventions. 1 patient experiences tracheal stoma or lip irritation, thick, tenacious secretions, pressure areas on neck or near stoma site. Implement measures to protect patient from medical device pressure injuries, MDPIs, see Chapter 39. Increase frequency of suctioning and airway care, see Chapter 25. 2 patient experiences continued hypoxia. Determine if cause of continued hypoxia is oxygen delivery device, plugging of airway, oxygen flow rate, or a new clinical problem. Notify healthcare provider of continued or worsening hypoxia. Recording and reporting. Record the respiratory assessment findings, method of oxygen delivery, flow rate, condition of tracheal stoma or lips, patient's response, any adverse reactions on the flow sheet in nurse's notes in electronic health record, AIR, or chart. Document your evaluation of patient and family caregiver learning. Report any unexpected outcome to healthcare provider or nurse in charge. Special considerations. Teaching. See teaching considerations for Skill 23.1. Home care. Some patients who are at home have both a permanent tracheostomy and AT tube or a tracheostomy collar. The patient or caregiver needs to be physically able to perform tracheostomy care and suctioning techniques and must understand how to manage oxygen, see Chapters 25 and 44. Skill 23.3 Using incentive spirometry. Incentive spirometry helps a patient deep breathe. It works by providing visual feedback that helps encourage the patient to take long, deep, slow breaths. Smetana, 2016. The use of an incentive spirometer, IS, alone is not recommended to prevent postoperative pulmonary complications. It should be used in combination with other pulmonary maneuvers such as deep breathing and coughing, early mobilization of the patient, and directed coughing. Do Nascimento et al., 2014, Smetana, 2016. The 2 types of ISS are flow-oriented and volume-oriented. Flow-oriented ISS have 1 or more plastic chambers with freely movable colored balls. The advantage of a flow-oriented IS is the slow, steady expansion of the lung. As a patient inhales slowly, the balls elevate to a premark area, Fig 23.14. A patient's goal is to keep the balls elevated for as long as possible to ensure maximal sustained inhalation. Even if a very slow inspiration does not elevate the balls, this pattern helps a patient improve lung expansion. Fig 23.14 Flow-oriented incentive spirometer. Volume-oriented devices use a bellows that a patient must raise to a predetermined volume by inhaling slowly, Fig 23.15. The advantage of the volume-oriented IS is that a patient can achieve a known inspiratory volume and measure it with each breath. Fig 23.15 Volume-oriented incentive spirometer. Delegation and collaboration. The skill of helping a patient to use incentive spirometry can be delegated to nursing assistive personnel, NAP. The nurse is responsible for assessing and monitoring the patient, evaluating the patient response, educating the patient about the proper use of the IS, and evaluating that education. The nurse directs the NAP by informing about the patient's target goal for incentive spirometry. Informing to immediately notify the nurse about any unexpected outcomes such as chest pain, excessive sputum production, and fever. Equipment. Flow. Step/rationale. Assessment. 1. Identify patient using at least 2 identifiers, example name and birthday or name and medical record number, according to agency policy. Ensures correct patient. Complies with the Joint Commission standards and improves patient safety, TJC, 2016. 2. Review medical record to identify patients who will benefit from the use of an IS, example existing pulmonary disease, obesity, debilitating chronic illness, heavy smokers, patients with a neuromuscular disease, or patients with sickle cell disease with acute chest syndrome, Smetana, 2016. In addition, identify selected postoperative patients who would benefit from combining IS with other airway clearance measures, Tyson et al., 2015. Alerts healthcare personnel to patients at risk for respiratory complications during illness or after surgery. 3. Assess patient for confusion, cognitive impairment, ability to follow directions, age, developmental level, level of consciousness, and decreased necessary motor skills, Smetana, 2016. Determines risks for difficulty performing incentive spirometry. Clinical decision point. Patients who are unable to follow directions or who are not developmentally or physically able to perform the actions associated with this skill are not candidates for this intervention. This assessment allows the nurse ability to identify whether to use the flow-oriented versus volume-oriented IS. 4. Perform hand hygiene. Assess patient's respiratory status, including symmetry of chest wall expansion, respiratory rate and depth, sputum production, and lung sounds. See Chapter 6. Also obtain a pulse oximeter reading. Reduces transmission of microorganisms. Decreased chest wall movement, crackles or decreased lung sounds, increased respiratory rate, or increased sputum production can indicate a need for incentive spirometry to improve lung expansion. 5. Assess level of pain at rest and during activity, example coughing, using a 0 to 10 scale. Pain decreases effective incentive spirometry by restricting chest expansion. 6. Review healthcare providers' order for incentive spirometry. Healthcare agencies often require a medical order for incentive spirometry to receive third-party reimbursement. Nursing diagnoses. Acute pain. Impaired breathing pattern. Impaired gas exchange. Ineffective airway clearance. Related factors are individualized based on patient's condition or needs. Planning. 1. Expected outcomes following completion of procedure. Patient demonstrates correct use of IS. Demonstrates learning. Patient achieves target volume and number of repetitions per hour. Demonstrates increased lung expansion. Patient has improved breath sounds and increased pulse oximeter reading. Incentive spirometry helps patient deep breathe and manage airway secretions. 2. Explain procedure to patient and family caregiver. Understanding purpose of incentive spirometry and its proper use improves compliance with use. 3. Indicate to patient where target volume is on IS. Note, if possible, demonstrate use of IS. Encourages patients to do better with each breath and meet or exceed target volume. When patients have a visual target, they can gauge their improvement. Implementation. 1. Gather equipment/supplies and complete necessary charges according to agency policy. Ensures that you have the necessary equipment. 2. Perform hand hygiene. Reduces transmission of microorganisms. 3. Position patient in most erect position, example high Fowler's if tolerated, in bed or chair. Promotes optimal lung expansion during respiratory maneuver. 4. Instruct patient to hold IS upright, exhale normally and completely through mouth, and place lips tightly around mouthpiece, Fig 23.16. Allows for proper function of IS, Smetana, 2016. Showing patient how to correctly place mouthpiece is reliable technique for teaching psychomotor skill and enables patient to ask questions. 5. Instruct patient to take a slow, deep breath and maintain constant flow, like pulling through a straw. If flow-oriented IS, inhalation should raise the ball. If volume-oriented IS, inhalation should raise the piston. Remove mouthpiece at point of maximal inhalation, then have patient hold his or her breath for 3 seconds and exhale normally. Maintains maximal inspiration, reduces risk for progressive collapse of individual alveoli. Clinical decision point. Some patients are unable to hold their breath for 3 seconds. Encourage them to do their best and try to extend the duration of breath holding. Allow patients to rest between IS breaths to prevent hyperventilation and fatigue. 6. Have patient repeat maneuver, encouraging him or her to reach prescribed goal. Ensures correct use of IS and patient's understanding of use. 7. Encourage patient to independently use IS at prescribed frequency. Frequently prescribed timing schedules of IS use are up to 30 deep breaths with 30 to 60 second rests between sets of 10. Smetana, 2016.
Cap.
Repeated use of IS improves lung expansion and promotes clearing of airways. Encouraging patients to perform independently gives them a sense of control over their care. 8. Perform hand hygiene. Reduces transmission of microorganisms. Evaluation. 1. Observe patient's ability to use incentive spirometry by return demonstration. Determines patient's ability to perform breathing exercise correctly. 2. Assess if patient is able to achieve target volume or frequency. Measures adherence to therapy and lung expansion. 3. Auscultate chest during respiratory cycle and obtain pulse oximeter reading, Smetana, 2016. Documents lung expansion, identifies any abnormal lung sounds, and determines if airways are clear. Identifies improvement in pulse oximeter readings. 4. Use teach back. I want to be sure I explained how and when to use the IS. Show me how to use your IS, and tell me how frequently you should use it. Revise your instruction now or develop a plan for revised patient teaching if patient is not able to teach back correctly. Determines patient's level of understanding of instructional topic. Fig 23.16 Proper placement of lips around incentive spirometer. Unexpected outcomes. Related interventions. 1. Patient is unable to achieve incentive spirometry target volume. Encourage patient to attempt incentive spirometry more frequently, followed by rest periods. Teach cough control exercises. Teach patient how to splint and protect incision sites during deep breathing. Administer ordered analgesic if acute pain is inhibiting use of IS. 2. Patient has decreased lung expansion and / or abnormal breath sounds or decreased pulse oximeter readings. Teach patient cough control exercises. Provide help with suctioning if patient cannot cough up secretions effectively. 3. Patient develops hyperventilation. Encourage longer rest periods between breaths. Recording and reporting. Record lung sounds, respiratory rate, and pulse oximeter readings before and after incentive spirometry, frequency of use, volumes achieved, and any adverse effects on flow sheet and nurse's notes in electronic health record, AIR, or chart. Document your evaluation of patient learning. Special considerations. Teaching. Teach patient to examine sputum for consistency, amount, and color changes. Sputum should become clearer over time and decrease in volume. Pediatric. Incentive spirometry is not typically used in pediatrics except for school-age children. A pediatric patient needs the fine motor skills and ability to follow instructions to use an IS effectively. Hockenberry and Wilson, 2015. Allowing a child to play with and try out the IS helps to decrease his or her anxiety and encourages participation in care. Use games or bubbles and pinwheels to encourage small children to take deep breaths. These activities help achieve the same goals as incentive spirometry in some children. Gerontological. Older adults with chronic illnesses or arthritis have difficulty coordinating the use of the IS. They require additional time to demonstrate the procedure. Ch23 and Jet, 2014. Weakened respiratory muscles and decreased elastic recoil properties of the lungs affect a patient's ability to cough and deep breathe. Therefore, it takes an older adult longer to achieve the target volume. Ch23 and Jet, 2014. An older adult may be more able to use the volume-oriented IS versus the flow-oriented IS. Lunardi et al., 2014. Skill 23.4 Care of a patient receiving non-invasive positive pressure ventilation. Non-invasive positive pressure ventilation, NIP or NPPV, or non-invasive ventilation, NIV, maintains positive airway pressure and improves alveolar ventilation without the need for an artificial airway. There are two types of NIP, continuous positive airway pressure, CPAP, and bilevel positive airway pressure, BiPAP. BiPAP and CPAP are usually applied via a mask covering the nose or both the mouth and nose, Fig 23.17, but those who require home CPAP may wear nasal prongs instead. Cross, 2012, Hill and Kramer, 2016, Puboni et al., 2013, Preston, 2013. Fig 23.17 CPAP mask. NIP is used both in acute care settings and increasingly more in home care settings to treat a variety of conditions, including obstructive sleep apnea, OSA, chronic obstructive pulmonary disease, COPD, cardiogenic pulmonary edema, respiratory failure, and neuromuscular disorders. It is commonly used in these conditions to avoid the complications of invasive ventilation strategies, including pneumonia and aspiration. Gale et al., 2015, Hill and Kramer, 2016, Puboni et al., 2013. It should not be used in patients who cannot protect their airway or in patients with an inadequate respiratory drive or apnea and should be used with caution in patients with facial injuries, uncooperative patients, or hemodynamically unstable patients. Cross, 2012. The advantages of this type of ventilation versus invasive ventilation include an increased ability to communicate with caregivers and family, better ability to cough and clear secretions, and allowance for eating and drinking. There are disadvantages, problems, and concerns to this type of ventilation. Table 23.2. The mask must fit tight and have a good seal to prevent air from leaking. This pressure can cause feelings of claustrophobia and intolerance in patients, which can lead to issues with adherence to therapy. The tight-fitting mask can also lead to skin breakdown, particularly on the bridge of the nose. Cross, 2012, Shalom et al., 2015. Table 23.2. Problems associated with continuous positive airway pressure and bilevel positive airway pressure. Problem. Cause. Discomfort. Mask that fits over patient's nose is tight-fitting. Oxygen flow rate causes dry mucous membranes. Psychosocial. Relationship with sleep partner is difficult. There are possible sensations of claustrophobia. Risks to skin integrity. Tight fit of mask causes diaphoresis, pressure, and increased risk for skin breakdown. Patients need to remove mask to relieve pressure. Hypercapnia. Although CPAP improves alveolar function, which increases carbon dioxide clearance from the blood, it also causes air trapping. In some patients this causes a rise in carbon dioxide levels. Initially you need to monitor patients' ABG levels. Gastric distension. CPAP/BiPAP force more air into the stomach, which causes distension and discomfort. Noise. Some patients find the older machines very noisy, interfering with sleep and leisure activities such as watching television or listening to music. ABG, arterial blood gas, BiPAP, bilevel positive airway pressure, CPAP, continuous positive airway pressure. Data from Puboni et al., Non-Invasive Ventilation Procedures, 2013, http://emedicine.medscape.com/article/1417959-overview, November 2015. Delegation and Collaboration. The skill of caring for a patient receiving non-invasive ventilation cannot be delegated to nursing assistive personnel, NAP. The nurse collaborates with the respiratory therapist when providing care for the patient. However, the skills of patient positioning, therapeutic coughing, and CPAP/BiPAP mask application can be delegated to NAP. The nurse directs the NAP by informing about the need to immediately report to the nurse any changes in patient's vital signs, oxygen saturation, mental status, skin color, or skin abrasions, bruising, or blistering around mask area. Informing about the need to immediately report to the nurse any ventilator or CPAP/BiPAP machine alarms or patient monitor alarms. Instructing on how to modify care such as for how long the mask can be removed, oral care, or any special skincare needs. Informing about the prescribed settings on the equipment and instructing personnel to immediately notify the nurse of any change in settings or patient comfort. Step/rationale. Assessment. 1. Identify patient using at least 2 identifiers, example name and birthday or name and medical record number, according to agency policy. Ensures correct patient. Complies with the Joint Commission standards and improves patient safety, TJC, 2016. 2. Assess patient's respiratory status, including symmetry of chest wall expansion, respiratory rate and depth, oxygen saturation, sputum production, and lung sounds, see Chapter 6. When possible, ask patient about dyspnea and observe for signs and symptoms associated with hypoxia, see box 23.1. Decreased chest wall movement, crackles or decreased lung sounds, increased respiratory rate, increased sputum production, or signs of worsening hypoxia may make patient a candidate for non-invasive positive pressure ventilation or changes in NIP settings. 3. Observe patient's skin over bridge of nose, around external ears, back of head. The mask can place pressure on skin and increase risk for skin breakdown, Shalom 2015. 4. Observe patient's ability to clear and remove airway secretions by coughing. Secretions plug the airway, decreasing amount of oxygen that is available for gas exchange in the lung. 5. Perform hand hygiene. Assess patient's vital signs, pulse oximetry, when available, note patient's most recent arterial blood gas, ABG, results. Objectively documents patient's pH, arterial oxygen, arterial carbon dioxide, or arterial oxygen saturation. Identifies need for NIP. 6. Assess patient's level of consciousness, behaviors, and ability to maintain and protect airway. Patients who cannot maintain their own airway or who are uncooperative are not candidates for NIP. Clinical decision point. NIP is contraindicated in patients in cardiac or respiratory arrest or with facial deformities, hemodynamic instability, inability to protect airway, severe agitation, excessive secretions, or high inspired oxygen concentration, FiO2, requirements, Wiegand, 2011. Its use in palliative care and end-of-life care is still being investigated, Gale et al., 2015. 7. Review patient's medical record for medical order for CPAP/BiPAP and appropriate settings. Healthcare provider's order is necessary for this therapy. 8. Assess patients' and family caregivers' understanding of purpose of CPAP and ongoing maintenance. Determines level of instruction required. Nursing diagnoses. Activity intolerance. Deficient knowledge regarding purpose of CPAP. Impaired comfort. Impaired gas exchange. Risk for aspiration. Risk for impaired skin integrity. Sleep deprivation. Related factors/risk factors are individualized based on patient's condition or needs. Planning. 1. Expected outcomes following completion of procedure. Patient has increased lung expansion. Patient experiences improved gas exchange when lungs are expanded. Patient maintains ABG levels and/or pulse oximetry, SpO2, readings improve or remain normal. NIP delivered appropriately based on patient assessment data. Clinical decision point. When first initiating CPAP/BiPAP, it is important to monitor gas exchange, especially in patients with COPD, cardiogenic pulmonary edema, or acute respiratory failure. You do this to observe for carbon dioxide retention. If patient has do not resuscitate orders or is receiving palliative care services, careful consideration is given before starting non-invasive ventilation, Preston, 2013. Patient experiences reduction in feelings of dyspnea and work of breathing. In patients with acute conditions, dyspnea usually improves. Patients with chronic pulmonary diseases often require nocturnal CPAP/BiPAP indefinitely to achieve long-term benefits. Patients' vital signs and respiratory assessment parameters improve. Reduced pulse and respiratory rate, improved mental status, improved skin color, and decreased use of accessory and abdominal muscles occur because patients' work of breathing decreases as level of oxygenation improves. Patient's skin around bridge of nose, ears, and back of head remains clear without breakdown. Mask applied properly and monitored for pressure occurrence. Patient able to describe how to use CPAP in the home setting. Demonstrates learning. 2. Explain to patient and family the purpose and reasons for CPAP/BiPAP. Helps reduce sense of claustrophobia from mask. In addition, information reduces anxiety and increases cooperation and adherence to therapy. Implementation. 1. Collaborate with the respiratory therapist to gather equipment/supplies and complete necessary charges according to agency policy. Ensures that you have necessary equipment to apply the NIP system. 2. Perform hand hygiene, apply clean gloves. Apply mask, gown, and goggles if secretions are projectile or if patient is in isolation. Reduces transmission of microorganisms and exposure to pulmonary secretions. 3. Adjust bed to appropriate height and lower side rail on side nearest you. Check locks on bed wheel. Minimizes caregiver's muscle strain and prevents injury. Prevents bed from moving. 4. Determine correct mask size. Use masking chart to determine correct size, S, M, L, XL. Note, it is imperative that mask have quick release straps. Mask should fit snugly over patient's nose, CPAP, or nose and / or mouth, BiPAP, to create a tight seal for delivering positive pressure. In case of emergency, example vomiting, respiratory arrest, quick release straps allow mask to be removed quickly. This system also allows patient to remove mask quickly as needed, ETAL, 2016. Clinical decision point. A patient receiving by a full face mask should never be restrained. The patient must be able to remove the mask if he or she begins to vomit, needs to remove excess secretions, or reposition a mask that has moved. A displaced mask can force the patient's jaw inward, which can obstruct the patient's airway, ETAL, 2016.
Oh no.
5. Connect CPAP/BiPAP device delivery tubing to pressure generator. Ensures that patient is receiving proper NP as ordered. 6. Connect patient to pulse oximetry. It is important to continually monitor patient's level of oxygenation when initiating NP. 7. Set CPAP/BiPAP initial settings per physician order. These settings allow healthcare team to determine initial patient response. A CPAP, 5 to 15 centimeters H2O is the typically prescribed pressure range, Puboni ETAL, 2013. CPAP provides single positive pressure throughout breathing cycle, which helps to keep alveoli open at end expiration. BiPAP, inspiratory pressure is usually set at 10 to 12 centimeters H2O initially and can be titrated up to 15 to 20 centimeters H2O as patient condition dictates. Expiratory pressure is usually set at 5 to 7 centimeters H2O initially and can be titrated up as patient condition warrants. Puboni ETAL, 2013. BiPAP supplies pressure at both inhalation and exhalation. The inhalation pressure is set according to healthcare provider's order and helps prevent airway closure. Expiratory pressure is set according to healthcare provider's order and keeps alveoli open at end expiration. Cross, 2012, Preston, 2013. 8. Select FiO2 level as indicated and per prescriber order. Patients on may also need supplemental oxygen to decrease signs and symptoms of hypoxia. Hill and Kramer, 2016. 9. Ensure that humidification and heating appliances are connected and on. Humidification of gas is thought to improve comfort in patients receiving NP. Restrepo and Walsh, 2012. 10. Ensure that mask is tight-fitting, no air leak is present, and there are no excessive pressure points. An ill-fitting mask leads to loss of pressure getting into airways or dyssynchrony with ventilator. It also can lead to air blowing into eyes, which can cause patient discomfort. Wiegand, 2011. Pressure points around mask area can cause device-related pressure injuries. Shalom ETAL, 2015. 11. If patient is to use CPAP at home, have patient or family caregiver demonstrate mask placement and adjustment of settings. Return demonstration indicates learning. 12. Dispose of supplies as appropriate, remove gloves and other personal protective equipment, and perform hand hygiene. Reduces transmission of microorganisms. 13. Continuous care of patient. A. Ensure that all alarms are on and active and that ventilator circuit is intact and properly functioning. Ensures patient safety. B. Ensure that emergency resuscitation equipment is at bedside. Allows for quick resuscitation in case of worsening patient condition. Wiegand, 2011. C. Investigate any and all alarms that come with ventilator/CPAP machine and / or patient monitor. Alarms can alert healthcare team to problems with patient or with circuit that adversely affects patient status. D. Change patient's position every 2 hours or encourage patient to change position every 2 hours. Reduces incidence of atelectasis or pneumonia secondary to stasis of secretions. Evaluation. 1. Observe for decreased anxiety, improved level of consciousness and cognitive abilities, decreased fatigue, and absence of dizziness. Determines patient's response to NP. As hypoxia and hypercapnia are reduced or corrected, patient's behavioral assessment parameters improve. 2. Measure vital signs, perform respiratory assessment and observe skin color, and ask patient to describe sense of dyspnea. Physical assessment parameters reveal oxygenation status. 3. Monitor pulse oximetry. Documents patient's level of oxygenation. When first initiating NP, it is important to obtain ABG levels in patients in whom abnormal gas exchange is suspected, after the first hour, and per agency protocol. 4. Observe skin integrity over bridge of patient's nose every 2 hours. Ask patient about level of comfort. Hill and Kramer, 2016. Mask that is too tight causes skin breakdown, and frequent skin assessment is necessary. Pittman ETAL, 2015, Shalom ETAL, 2015. 5. If NP is planned for use in home, observe and monitor patients and family's ability to manipulate CPAP or BiPAP machine/ventilator and face mask. Determines patient's ability to perform self-care and adhere to CPAP/BiPAP plan. Success of non-invasive ventilation depends largely on patient acceptance and adherence. Gale ETAL, 2015. 6. Use teachback. I want to be sure I explained how NP works and why you are receiving this therapy. Explain to me why this therapy is necessary. Revise your instruction now or develop a plan for revised patient or family caregiver teaching if patient or family caregiver is not able to teach back correctly. Determines patient's and family caregiver's level of understanding of instructional topic. Unexpected outcomes. Related interventions. One patient experiences hypoxia, hypercapnia, or other signs of worsening respiratory function. Notify healthcare provider. Reassess patient. Determine correct settings and integrity of NAP. 2 patient develops skin breakdown at mask sites or sites where mask straps are located such as bridge of nose, nasal septum, or ears. Notify healthcare provider. Place protective synthetic coverings on nasal bridge or areas of irritation/possible irritation to protect skin. Fit mask so it is tight enough to not cause air leak but loose enough to not cause skin breakdown. Reassess patient, Puboni et al., 2013. 3 patient state sense of smothering or claustrophobia. Explain system to patient again. Demonstrate use of quick release straps. Have patient demonstrate use of quick release straps. Force stomach distension secondary to positive pressure air being forced into esophagus and trachea, Puboni et al., 2013. Notify healthcare provider. Be prepared for possible insertion of nasogastric tube, see Chapter 35.
Great.
Recording and reporting. Record respiratory assessment findings, CPAP/BiPAP settings, vital signs, and pulse oximetry, patient response, patient teaching outcomes, and skin assessment on flow sheet and nurse's notes in electronic health record, AIR, or chart. Document your evaluation of patient and family caregiver learning. Report to charge nurse or healthcare provider sudden change in patient's behavior or respiratory status and any decline in ABG levels or pulse oximetry values. Special considerations. Teaching. Teach patient and family caregiver the prescribed hours to use the machine. If not in use for 24 hours/day, work with the family caregiver to identify the ideal time for use, example bedtime, watching television. Teach patient and family caregiver how to apply the mask, connect it to the machine, and add oxygen if ordered. Instruct family caregiver to bring the machine, along with a list of correct settings, to the hospital anytime patient is admitted. Home care. The durable medical equipment provider, the home care nurse, and the primary care nurse develop a teaching plan to ensure that patient and family have working knowledge of the system before discharge. When patients require home NAP, instruct in complete care of the CPAP/BiPAP system. Skills include assembling the system, cleaning it, and maintaining the equipment daily. Teach patient and family caregiver what to do in case of respiratory distress or power failure. Notify appropriate power company so, in the event of a power outage, the home is on priority for restoring power. Follow the safety precautions for oxygen use, see Box 23.3. Procedural Guideline 23.1. Use of a peak flow meter. For patients who have measurable changes in the flow of their airways such as patients with asthma or reactive airway disease, peak expiratory flow rate, PEFR, measurements are useful. The PEFR is the maximum flow that a patient forces out during one quick, forced expiration and is measured in liters per minute. Use these measurements as an objective indicator of a patient's current status or the effectiveness of treatment. Decreased PEFR may indicate the need for further intervention such as increased doses of bronchodilators, anti-inflammatory medications, or even seeking emergency medical attention. Normal PEFR values vary according to a person's age, gender, and size. Patients with asthma perform PEFR measures in the home to monitor the status of their airways. Healthcare providers usually recommend that patients measure and record their PEFR during the following times, same time every day. Values are lowest in the morning and typically highest between noon and 5 p.m., before taking asthma medicines, during asthma symptoms or an asthma attack, after taking medicine for an asthma attack, and other times recommended by their healthcare provider, NLBI, 2013. Delegation and Collaboration. Initial assessment of the patient's condition is a nursing responsibility and cannot be delegated. The skills of follow-up PEFR measurements in a stable patient can be delegated to nursing assistive personnel, NAP. The nurse instructs the NAP to report immediately to the nurse patient's difficulty breathing or decrease in PEFR measurement. Equipment. Peak flow meter, Fig 23.18. Fig 23.18 peak flow meter. Courtesy Philips RESP Ironics. Patient diary/action plan, if appropriate. Procedural steps. 1. Review medical record for patient's baseline PEFR, if available. 2. Assess previous PEFR readings and the target set by patient's healthcare provider. 3. Help patient to stand or to high Fowler's position or any other position that promotes optimum lung expansion. 4. Assess patient's baseline knowledge of when and how to use PEFR and correct response to results. 5. Slide clean mouthpiece into base of the numbered scale. 6. Instruct patient to take a deep breath through nose and slowly blow out through mouth. Take second deep breath. 7. Have patient place meter mouthpiece in mouth and close lips, making a firm seal. 8. Have patient blow out as hard and fast as possible through mouth only. 9. Monitor PEFR results and assess if patient is in expected range. 10. Inform patient of his or her individualized acceptable range and mark on meter. 11. If patient is to record PEFR at home, have him or her demonstrate how to record it accurately on chart using traffic light pattern. A system of asthma zones green, yellow, and red is commonly used. Green indicates that the PEFR is 80% to 100% of patient's personal best value and means that he or she should continue with the currently prescribed treatment regimen. Yellow indicates that the PEFR is 50% to 90% of the personal best and that the person should add the prescribed quick relief medication to the treatment regimen and continue with his or her daily long-term control medications. Red indicates that the PEFR is less than 50% of the patient's personal best and that the person should take the prescribed quick relief medication and seek medical attention. N. by 2013, Fig 23.19. Fig 23.19 Asthma Action Plan. From Hockenberry M.J., Wilson D., Wong's Nursing Care of Infants and Children, ed. 10, St. Louis, 2015, Mosby. 12. Use TeachBack. I want to make sure that I showed you how to correctly measure your PEFR. Show me how you would use this PEFR device. Revise your instruction now or develop a plan for revised patient or family caregiver teaching if patient or family caregiver is not able to teach back correctly. 13. Compare patient's PEFR with his or her personal best. 14. Record PEFR measurement before and after therapy and patient's ability and effort to perform PEFR in electronic health record, AIR, or chart. 15. Instruct patient to clean unit weekly following manufacturer instructions.